All right, as folks join us, I think we'll go ahead and get started. We've got a chock full agenda today, and just want to orient you a little bit to what we're hoping will be outcomes from our time together, and then just dive right into a phenomenal program. So I'm Suzanne Watts-Henderson, and I'm a senior consultant with Interfaith America. I'm leading our sort of overarching initiatives at the intersection of faith and health, which is a new practice area for Interfaith America, has grown in part out of our work on campuses with many of you, in part out of our work in the community through our Faith in the Vaccine outreach. And we are looking to bridge this divide between faith and health in a comprehensive way. And this conversation is a part of that. Today's conversation kind of grows out of two expressed needs from our community. One is folks want to hear more stories from the field of what's happening at the intersection of faith and health. And so we thought where better to turn than to our emerging leaders, young leaders in various health spaces with various faith traditions who are working at this intersection. And then also just the chance to connect. A number of you have been a part of our Faith and Health Grants program. You've been working with students, sometimes in the community. And you said, hey, can we have a place where we come together across the country to learn from one another, to listen to what is happening? So we've designed a time together that we hope balances both of those things, storytelling and connection. And so without further ado, I'm going to hand the virtual mic, off to Rachel Klein, who has been such a pillar of this Faith and Health Grants work. She's Program and Grants Manager at Interfaith America, and she's gonna help us move all along. Thanks, Rachel.
Thanks, Suzanne. It is so wonderful to see so many folks here, so many both familiar and new names, which is so exciting. Our first speaker I would love to highlight is Janice D'Souza. Janice was born and raised in South India and is professionally a mixed methods researcher and evaluator with a focus on gender, sexual and reproductive health, religion, and social inequalities. She has worked at the intersections of the CDC, the NYC Department of Health, and girls' education programming in India. She has also worked as an evaluator with the national advocacy groups on matters of safe abortion and family planning, and instructs youth, parenting adults, and teachers in sex education. She is a Master of Public Health from Emory University with a focus on sexual and reproductive health, and a BA from Berea College in Gender Studies. She is the happiest reading Bollywood gossip, twisty mysteries, and in kitchens. And so we are so excited to introduce her.
Everyone, really happy to be here. I'll get started. So I grew up Roman Catholic in South India. I got my schooling at Catholic and Hindu institutions, and in the United States, I received my healthcare at a Catholic hospital. I donated blood at the Lutheran Church, and I got my Indian food when I was really homesick during Langar at a Sikh Gurudwara. So I feel like religiously diverse communities are integral to personal and community health in essential ways. I was interacting with faith-based organizations and places of worship to receive care, receive food, receive vaccines, and I suspect you may be also. Faith-based organizations already deliver significant and vital social services. So religious communities are also powerful reservoirs of trust, social capital, and with a unique ability to serve as partners in promoting positive health. I've been very fortunate to be able to work in public health at the intersection of sexual and reproductive health and faith. It's very specific. And the first time I experienced this confluence of faith and public health was during a project as an early researcher around menstrual health management in India. And it was housed in a larger project around waste management and infrastructure. And at first, my first thought was, what is the connection? Why can't we just build these toilets and surely they'll be used and then we can move on? But I quickly realized I was wrong. And you'll see throughout, I've been wrong many, many times. And was taught by elders that engaging key community influencers is part of their social fabric and part of that work. And we know an influencer could be someone on TikTok, Instagram. No, over here, it's a community health worker or a teacher who works closely with adolescents But faith leaders are also key influencers, especially when you want to engage with the larger community. So for that social fabric, ensuring all members of the community, including boys and men, are aware of menstrual hygiene as important as it feeds into the provision of an enabling environment. And this enabling environment is where it could confluence construction of more bathrooms, garbage bins for disposal of menstrual products. It could influence a person's ability to go to school or work. Another learning around that time that I had was around stigma. And that is my own stigma because I have to work through, and also societal stigma, because menstrual stigma can revolve around menstrual practices, which is why it's even more important to engage faith leaders in trying to dispel it. For example, in some parts of India, we found that people who menstruate are often not allowed to touch religious scriptures or visit a place of worship if they're menstruating. And this was annoying to some people, but some also viewed this as a relief from religious duties. They see that God has taken their physical needs into consideration. So whether negative or positive or just neutral, ideas around menstruation and its effect on people can really define lives. I also found that whatever the explanation, taboos matter. They shape how we view our own bodies. Studies have shown that people from traditions with rules around their body were more ashamed and secluded compared to other individuals, and we certainly don't want that. But the same studies have also shown that these individuals had a stronger sense of community than those without menstrual rituals. And that's the lesson, right? Because though these rituals could keep women apart, it also gave them a space with each other. So rituals were not the issue. The problem is the underlying shame and the stigma. I later received a master's in public health from Emory University and completed my religion and health certificate, which allowed me to take classes in the divinity school with divinity students. And again, furthered the importance of synergy between public health professionals and faith leaders. A project I'm currently working on is creating sex education toolkits for faith leaders to use in their communities, primarily with adolescents. And I'm doing this with the Interfaith Innovation Fellowship with Interfaith America. I conducted a focus group with faith leaders in our alumni network who engage with youth in their work. And here are two, maybe three findings that have stayed with me. One, parents of adolescents are turning to faith leaders to have conversations around sex with their teens. And teens are also seeking guidance and are asking for support. All great news. But there is just too much information out there on sex, most of it on TikTok, some evidence-based and some not. Those conversations with families and teens could be more effective if we had evidence-based information to just bolster and boost that conversation through. The second learning I had was that faith leaders are most involved during moments of crises. By the time they are called, an assault, an unintended pregnancy, harsh words around sex have already been spoken. And the third one is that the assumption that places of faith don't talk about sex. Because it is being talked about, maybe in some harmful ways, but the topic is being brought up. And sometimes the harm is not done with the content of what's being said, but harm is done when the adult or faith leader has to wade through their own awkwardness about the topic and avoid talking about it. So there's a lot of scope here for us to move that needle from like harmful to at least neutral, and hopefully very quickly or sometime to positive. So synagogues, churches, other local ministries, related to other community groups are among the most significant in connecting with teens and are an important resource for adolescent socialization and development. Outreach to youth is sometimes the most important mission of many religious institutions. And so we have to there's a lot of scope here to leverage that and take it forward. Moreover, congregations may be ideally positioned to reach out to parents of teens with information and spiritual directions on matters of adolescent sexuality. Temples and other places of worship frequently involve both parents and children, and families commonly turn to these communities for guidance in sexuality, contraception, relationships, and intimacy. I will end this by saying religion and culture, I think, form the core fabric of people's belief systems, and failing to engage our religious diversity really leaves a very powerful resource on the table in promoting equitable health across the nation. Thank you.
Thank you so much. You have left us with a lot to think about and a lot to process within our groups. And thank you so much for your commitment to the work. We truly appreciate it. So as we have thought about, and as Janice just shared with us, the intersection of community, public health, faith, we are going to send you all to your first breakout group, in which we are asking you and your group to discuss how can faith communities play a constructive role in health? And feel free to introduce yourselves. Feel free to take time to get to know each other. You'll be in the same groups throughout. So just this first time you'll introduce each other and then spend some time processing through. Once again, you can go back to the Padlet if you also want to write down some answers. So we will see you back here shortly. Up next, our second health leader, we are so excited to introduce. Muzzammil is a current research fellow at NIH's National Cancer Institute. He holds a Bachelor of Science from Johns Hopkins University, where he studied molecular and cellular biology and found his passion for the intersection of faith and health. This passion drove him to establish and direct Anis, a patient visitation service conferring spiritual companionship and emotional availability to hospitalized Muslims. His interests are in medical education, health policy, health disparities, and the intersections between spirituality and healthcare. Thank you so much for joining us today.
Thank you so much, Rachel, for that very kind introduction. You guys are way too nice to me. It's more than I deserve. I appreciate it. And also, just before I begin, I apologize. My voice was already insufferable as is. And recently I've had a lot of congestion, so I can only imagine how bad it is now. So I very much appreciate you guys sticking with us and coming here and attending these amazing events. So thank you guys so much. It was really difficult because it's hard to boil down all the experiences that I've had into an 8-minute story. Like I told Suzanne the other day, I could talk for days about the things that I've seen, the people that I've interacted with. And that's really why I do this. It's the most amazing feeling in the world to be able to walk into a patient room and listen and hear their stories and see where different people come from different places and have so many different experiences. But so I really didn't know where to start today, but there were two profound moments that I've had in my experiences that I really wanted to share, because I don't think I could tell my story or the story of Anis, the patient visitation service that I established, without telling these two specific epiphanies that I had. The first being the difference between the term cultural humility versus the term of cultural competence and its importance in the clinical workspaces as it pertains to the intersection of faith and medicine, the way I've seen it. And the second one that I wanted to share is really our responsibility to take initiative and serve our community, which I'm sure everyone here in this call is really active in doing. And so to begin, the first profound moment that I wanted to share was actually while I was visiting one patient, just me knowing that my culture, I'm Muslim myself and I visit Muslim patients. I know that as a Muslim, females, they are religiously inclined to cover their hair. And so whenever I would visit upon a Muslim female patient, one of the things that I would do is I would knock on the door and I would introduce myself. I would not walk in yet. I would knock on the door, I would introduce myself, and I would ask for permission and give some time before I entered into the room. And that was just something that I did out of habit because I understood our culture and that's just how we do. But it was not until a few nurses, they actually stopped me from the nurses station and they said, we noticed that every time you visit female patients, you stop and you wait for a little bit outside and then you introduce yourself and then you walk in. Is there any particular reason you're doing that, and should we be doing that? And it was in this moment where I realized that the term cultural competence is a beautiful term and I love it, but and I'm very optimistic, and so I would love to one day be competent in every culture there is. But these nurses in that moment were not technically competent in how to best support the cultural needs of these Muslim patients, because especially in front of male staff who may be entering into these patients while their hair is not covered, obviously they do not do so intentionally, but they are unintentionally unaware of this. And so in that moment I realized that they may not be culturally competent, but I was blown away by their cultural humility, because they were so humble and they were so willing to help and to support. And it was almost as if in that moment they were telling me, please, I want to support these patients, I want to be there for them in whatever way they need me to be, please let me know how. And so that was very, very striking. And so I found a newfound love for the term cultural humility, because at the end of the day, what more can we do but really take into account the people around us are all different. I might not understand what it is you do, what it is you need me to do, but please explain it to me so that we can support one another and uplift one another. And the second epiphany that I really wanted to share, I think it's the one and only time that a patient has ever gotten mad at me, and really furiously mad at me, when I was visiting her. And I've never had this experience. It was so different, because every time I would visit a patient, they would be so happy to see me. But there was this one, I still remember, her name was Ruwaida, and she was on the leukemia service in Baltimore. And she was so upset when she saw me. She was so angry. As soon as I walked in and I introduced myself, and it took her a second to get all the curse words out of her system, and I don't blame her for it. She was going through a very difficult time. But after she said what was on her mind, she said, "Where were you last week? Where were you last month? Where were you? I've been here for months. I've been in this hospital." And I had to explain to her, I said, "Ms. Ruwaida, this is actually my first week starting here in this hospital. I was not here the week before. I was not here the months before." And so that's when I realized that she wasn't upset with me because I was visiting her. She was upset that it took me this long to visit her, considering that she was in this hospital for months at a time. And so that really actually made me very sad, because to this day, I try not to live with too much regrets, but I would say that one of my biggest regrets is that I did not get involved sooner in the work that I did. I did not get in contact with Interfaith America sooner, because I wish I had. And so that's really the second epiphany that I wanted to share, because at the end of the day, I do not want to place blame either on the hospital system, on our communities, on ourselves. There's enough responsibility to go around in terms of how we can best implement our services and really take care of our community, whether it be in a clinical workspace, in a community workspace, in a community center. It's just a really beautiful setting in terms of being able to support one another in whatever way it may be. And I think that at the end of the day, it falls upon each of us as individuals to be able to step up and see that, hey, I might not have a lot of time, but if I have a little bit of time, I might be able to dedicate it in a way where we can perhaps establish something, or perhaps set something that is ongoing. And really quickly, I know that I ramble a lot, and I'm very sorry for that. But one last thing that I wanted to share is on the similar wave of thinking, when I first got involved in trying to establish a spiritual care visitation service for Muslim patients, the hospital that I first started it at was actually very eager to welcome me on. But I had to check them for a little bit. I said, give me a little bit of time, because when they wanted to bring me on board, what I realized was they just wanted me to visit patients weekly, bi-weekly, whatever my availability was. And I had to let them know, I said, I graduate from this area and I might be moving in 2 years. Will it go back to how it was before, where nobody is visiting the Muslim patients? Like that's not something that I want to do with a temporary fix to a permanent solution. Compared to a permanent solution. And so actually I told the hospital to give me some time, and I spent a couple months in trying to establish this program, because I wanted to hopefully do something that Interfaith America is doing, try to build something that is long lasting, that is not dependent on one or two people. And so with that in mind, I just wanted to share these two experiences that I had, these two reflections that I had, and I'm very much looking forward to learning from everyone here. And thank you guys so much for having me. It's been a blessing.
Thank you so much for sharing your story. As you were talking, I was thinking, I've heard the quote, the best day to start something was yesterday, the second best is today. And so thank you for starting your work and continuing your work, and encouraging all of us to do that as well today. And thank you for talking about the structural changes to make to a whole system, so we are not relying on just one person to care for others. So as we think about all that you have shared with us, we are going to enter into the breakout groups again to think about how can spiritual support play a constructive role within the healthcare system. A perfect example of doing this not alone, but together in community is our next speakers. We have a duo. So we have Laura and Anu. Laura is an oncology certified nurse, and throughout the pandemic was struggling with what does it mean to engage in healthcare. Like many mystics before her, she believes that contemplation and action cannot be separated, and finds herself naturally helping others build reflective, imaginative, and spiritual practices to ground their action and work in the world. In partnership with Anu, who is a public health practitioner and pediatric hospitalist, they founded Introspective Spaces, a social venture committed to building reflective space and community for women in healthcare. We are so excited to have them today. Thank you so much.
Because of your graciousness, I'll go ahead and share our stories together. I'm a nurse. I was compelled to this vocation as an expression of my Christian faith, which I believe is faith as action. Before I was a nurse, I was a campus minister with InterVarsity. And although I loved that work, I wanted to be in line with the version of religion as described in the book of James. True religion is this, to take care of the widows and the orphans. I was really excited to join a career standing on the shoulders of many of my faith heroes, such as monastic communities who opened some of the first Western hospitals. When I arrived at my oncology new grad program, I was shocked by the cynicism of my fellow nurses. The pace was staggering, and I had no time to process the suffering I was witnessing. In fact, I often felt like I was creating or prolonging unnecessary suffering. My body responded with panic attacks. This landed me in employee health several times with getting EKG. They told me, drink more water. I felt ashamed and that I couldn't handle it. And that even more shockingly, everybody else was fine, getting on okay. This isn't what I had envisioned. Naive, perhaps. I learned quickly that what motivates healthcare is not people, but profits. And who suffers? The patients, but also the staff, because our well-being is inextricably bound together. The pace of this work leaves us without a shred of a second to reflect or make meaning of any of it. Christian thinker and philosopher Dallas Willard says, "Hurry is the great enemy of the spiritual life." And never did this feel so true in my first month as a bedside nurse. A lot of the suffering we experienced, was caused by structural problems within the healthcare system, such as not having enough staff. I later learned this feeling of helplessness and anxiety is called moral distress. Moral distress is knowing what is right, but not being able to do so due to systemic constraints. I didn't have a language for this at that time. It moves healthcare workers from a place of I did a bad job to I am a bad nurse. This inability to act in line with our values and beliefs is a spiritual injury. We are facing a spiritual epidemic in the healthcare workforce and the healthcare system. We are stripped of all meaning-making tools, leaving us bankrupt to understand our experiences while asking us to leave our rich religious and spiritual traditions at the door.
For me, visiting India while growing up and witnessing the abject poverty that existed, I knew I wanted a career focused on helping others. Medicine seems like a great way to do that. I didn't explicitly connect this passion with my faith tradition until I started college and began my own exploration of my Hindu Buddhist faith traditions. I started a meditation practice, began to read the Bhagavad Gita, a Hindu spiritual text, and I was really inspired by its call for a life of righteous action, one where we relinquish control of its outcomes. And this only solidified my passion for medicine because it felt like a way to live out my spiritual commitment to service. As I progressed in my own medical training, I started to encounter more and more situations that were just difficult for me to reconcile. And during my residency training as a pediatrician, I felt a deep sense of distress about how I could reconcile the injustices that exist in the healthcare system. And graduating in the pandemic, I was left feeling lost and uncertain about whether there was even a place for me at all as a practicing physician. Laura and I had been friends for many years prior to our healthcare careers, but found ourselves in conversation more and more as we grappled with how to navigate moral distress and the dissonance between the call to justice from our faith traditions and the way that the healthcare system was structured and organized. And on a particular hard day when I was working in the neonatal intensive care unit where we cared for premature babies, I called Laura to share the story about one particular premature infant I was taking care of who was very sick. There wasn't much more we could medically do for them, and I was extremely distraught. And in that moment, I knew there was not a medical or clinical solution. I just needed a space to share what I had witnessed and to honor the humanity of the family I had cared for. This was not something I had time for at work.
We started Introspective Spaces out of a core desire to create a community for what we both deeply needed. Spaces to acknowledge all the parts of our identity, including our cultural and spiritual identities, and opportunities to connect with other women in healthcare in a meaningful way. We kept hearing people talk about burnout, but what we really needed is for people to talk about moral injury. And I see that's a question in the chat. Would love to talk about it all the time. And the structural causes for this. This push for self-care and healthcare is needed, but frankly, it's exhausting and inadequate on its own. We believe that community care in the form of witnessing each other's experiences and stories is the first gift we can offer one another as healthcare workers as we work towards a future of collectivized care and action.
And so many cultural and faith traditions talk about how our commitment to service must originate from a place of well-being. And we love this quote from activist Grace Lee Boggs, who shared, "Transform yourself to transform the world." We truly believe that for us to serve patients with love, compassion, and provide equitable care, we also need to actively ensure that we are the best and most present version of ourselves when we come to work.
We love the sentiment shared by U.S. Surgeon General Dr. Vivek Murthy. He talks about, in the world of public health, we sometimes have a shyness or difficulty talking about spiritual health. He thinks about the conversations that he's had with patients, and he noticed that they landed on their spiritual traditions for support, for healing during difficult times. And the more that we're able to talk about these openly and explore these sources of suffering, the more readily we'll be able to improve our well-being as healthcare workers and for our structure of healthcare. If patients can rely on it, why can't we? Part of our hope for our community is opening up the conversation around what can sustain us. What has sustained us in the past? And what about the traditions of where we come from? We are interested in questions of how our spirituality informs how we show up clinically. Is it something we want more of? Is it a source of shame? If so, why?
And our work with introspective spaces is to create space for healthcare workers to gather in community. And we've done it through virtual workshops, retreats, in-person retreats. And these community spaces have been such a source of joy and restoration because it reminds us of how we all crave companionship and the desire to be seen. And I always think of one of the most joyous parts of our most recent retreat was watching women in healthcare from different faith backgrounds, spiritual worldviews, different healthcare roles, all engaging in a collage practice and walking the labyrinth, meditating together. And it reminded us of how we all need space to reconnect with ourselves, each other, and to remind ourselves that we are all part of something much bigger.
Our temptation may be to hide our colorful religious, spiritual, and cultural traditions to fit in with a one-size-fits-all healthcare system governed by policy and protocol. But I want to encourage all of you to take pride in the traditions that have held you and cared for you, and remember to use the wisdom you've been given. It is truly a gift and one we quickly forsake in a system that prioritizes body over spirit. Prioritizing your faith in an embodied way is swimming upstream in healthcare. But despite that, you are in good company. Remember, you are in company with us and with many others. Look at the 60 plus people here who are seeking to bridge the faith and health divide, and that perhaps your faith may be your greatest gift to yourself and your patients. We may only be a small piece of the pie in healthcare, but we believe only a small remnant is needed to reimagine healthcare and well-being on both the structural and individual level. Our traditions and gifts will be key in solving the moral distress and injury epidemic we are facing.
We know that you will find kindred spirits along the way, but if our stories resonate with you, we'd love to invite you to journey along with us as we build community around contemplation, care, and action for women in healthcare. We have our website in the chat, so feel free to read our newsletter, and you can find us on Instagram as well at Introspective Spaces.
We'll leave you with a final question. I know many of you are far along in your career teaching others already, but I want to ask what kind of healthcare worker or professor or chaplain, et cetera, do you want to be? And I don't mean a pediatric nurse or an ED physician. I mean a nurse who remembers the color of their patient's eyes, or a wise and compassionate doctor, or a mindful chaplain. Take a moment to think about one thing and hold this intention closely and let it be your one thing. I dare you to surprise someone with your response next time they ask what kind of specialty you are or want to be. And if you feel so bold now, you can drop what kind of healthcare worker you want to be in the chat. Thank you for seeking out the space to thoughtfully imagine who you set out to be in this work.
Yeah, thank you for having us.
For sharing of yourselves and your stories and your organization. So Laura at one point had posed the question, what has sustained us? And then at the end, the two posed the question, who do you want to be? So those are going to be our two questions in the breakout room of what stories from your cultural background or your spiritual worldview inspire you. And we'll end it with, who do you want to be? So we'll see you back here shortly.
What a rich lunchtime conversation for most of us. And sticking with the pie metaphor, the little slice of pie, my tradition has a saying about just a little leaven, leavening the whole dough. So I hope you get the sense from these conversations with our emerging leaders and the conversations that you've had in your groups today that we're on the front edge, I think, of a growing movement to reclaim religious identity, religious traditions, and all the resources they bring to strengthen our personal and public health. We're excited that you're a part of that. Rachel has just dropped the Padlet again into the chat so that you can continue this conversation. You'll be hearing from us by way of follow-up, and we hope that you will reach out to us as well as we begin to coordinate the many dots on the landscape across the country where exciting things are happening at the intersection of faith and health. We're bringing folks together for great conversation, but even more than that, for action. So we look forward to your being a part of this emerging movement wherever you are, whether you're a student who will be in the health-related world at some point, whether you are a faculty teaching those students, or whether you are already in health systems broadly across the country. We're glad that you're here, and stay tuned for more. Thanks for being here. And Rachel's going to close us out with a few little details, I think.
Yes, thank you so much. So speaking of continuing the conversation and merging this in a large integration of faith and health, as folks also noted earlier, policy impacts this as well. So you can find upcoming virtual events at interfaithamerica.org/event. We have a webinar next week debriefing the midterm elections that happened recently. We also have a number of articles and resources at Faith and Health, our Faith and Health website section on Interfaith America. Lastly, if you really want to continue conversations about interfaith cooperation, we have released a podcast, Interfaith America with Ibu Patel, and are offering $25 gift cards to folks who want to listen on their own, or $250 to folks who want to bring a group of people together and have a large group conversation. So this does not have to stop here. We truly hope it does not. Please remain in touch with us as we move forward, and let us know if you have any questions.
And I'm going to chime in with the thing I forgot that was on my list that I didn't look down to remind myself of. This is really exciting. Seniors, graduating seniors are eligible to join our Emerging Leaders Network. And within that broad Emerging Interfaith Leaders Network, there's a special sector devoted to healthcare. And all of our speakers today came from that sector. If you're a graduating senior, or you know of graduating seniors who would be interested in joining this network, please reach out to us or to Anastasia Young, who is with us today and leads that network and has included her email in the chat. So just one of many opportunities to stay connected.
Thinking of many opportunities to stay connected, especially with students and folks looking for professional development, we will be sending out this as a recording. Folks in the Padlet had asked about sharing resources. We would love for you to integrate this in your courses, in meetings you might have, sharing it with your students. So this is also a resource for you and for your students and folks looking to join our community.